So this is an hour-long webinar, 45 minutes of chatting, and then we're going to take some Q&A. Just as Andrew said, we're going to talk about, oh my goodness, I leak pee now. Now what should I do? As Andrew said, we're here in Vancouver, in North Vancouver, and I would like to respectfully acknowledge that I live, work, and play on the traditional unceded territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations here in British Columbia. Thank you for joining us from wherever you happen to be. My name, as mentioned, is Gillian. I've been a physiotherapist for 24 years, and I've worked 19 of those years in pelvic health. I am married to a mechanical engineer. I have a couple of kids that are just about to fly the coop. And I work at Canopy Integrated Health in North Vancouver. I also happen to be the co-host of a health podcast by the name of Small Conversations for a Better World. And there's one conversation in particular that may be another way to deepen your knowledge. It's by a learned colleague of mine, Samantha Hughes, about her book that she wrote on optimizing recovery from prostate removal surgery. So you can search for that anywhere you get your podcasts. Tonight, we're going to talk about how to manage urinary incontinence. What is it? Why is it happening? And what the heck you should do about it? Do you need an incontinence management system? Yeah, you do. And there's several key players involved in an incontinence management system. And those are often best used together in some way. So I'm going to go through those things. I'm going to talk about what pelvic floor physiotherapy is, because it is helpful for a lot of kinds of urinary incontinence. Notice that I said helpful. I didn't say necessarily cure, but helpful. We're going to talk a little bit about what happens if you're still leaking at the end. And actually what we're going to start with is, what is the goal? The goal, if you happen to have urinary incontinence, is to figure out how to live this life fully and with joy. And to do that, you need to have full confidence in your incontinence management system. So I would love for you to all to just take this moment and think about, okay, what's an activity right now that I would really enjoy a whole lot more if I didn't have this incontinence, or if my incontinence were better managed and I wasn't afraid of leaking. Usually the leaking publicly is the thing that really gets us down. So have that idea in your mind. What is this activity you'd really rather be able to do that would improve your quality of life right now? And as I go through the next few slides, you might be twigged into a direction of like, I haven't tried that yet, and I didn't know this. My hope for everybody is that you come away with one little piece of knowledge that you might not have had before. And if you're new to this journey, I hope you have a lot more pieces of information that you didn't have before. So we start here with, what is urinary incontinence? You're incontinent anytime you leak pee when you didn't mean to pass it, right? You didn't mean to, and the pee is coming out. That's incontinence. It can happen for various reasons, and that's typically how it's named. So you'll hear me toss around terms tonight like stress incontinence and urge incontinence. You can have mixed incontinence. You can have overflow incontinence. All of these things are talking about urinary leaking. Just what is the mechanism involved in that leaking is what determines the name. You can also have incontinence of fecal matter. Yes, that's poop. And of gas. So having flatulence that you can't control is a kind of incontinence, and also can be helped with physical therapy. So something to keep in mind. We're going to mostly focus on urinary incontinence today. I'd say entirely focus on it. And mostly we're going to talk about stress and urge, because those are the two most common types of incontinence. So stress incontinence. Anytime you leak pee when there's a movement, a cough, a sneeze, a laugh, is considered stress incontinence. So anytime we move or we use our abdominal muscles, pretty much any muscle at all, actually, we increase the pressure inside our intra-abdominal cavity. That pressure is pushing downward. And so I'm going to show you, hopefully you can see my little video. This is your bladder right here. And if you cough, sneeze, laugh, move, that pressure comes down, it squeezes your bladder. And here's your pelvic floor. If you don't have a strong enough pelvic floor, out comes the pee. That's stress incontinence. It's sort of as simple and as complicated as that. Urge incontinence is a bit different. It's the loss of urine with a strong or uncontrollable urge. It is often associated with having overactive bladder. And overactive bladder is just characterized with having a lot of urinary frequency and a lot of urgency. You can have urgency and frequency and not have leaking, but they often go together. And often what happens is you start with urgency and frequency, and it leads to incontinence, urge incontinence over time. And these are very common features of having benign prostatic hyperplasia. Some of you probably already know what that is, but we're going to talk about it a bit later. There's a few kinds of incontinence that I actually really need to give you a public service announcement about. You need to seek medical attention for any incontinence that's new to you. So if you're on this call and this leaking thing has just started happening and you haven't talked to your doctor, please, that's your first step. Go to your doctor. If you cured your incontinence, you were incontinent before, but you cured it, and then all of a sudden out of the blue, it's come back, I want you to go to your doctor. You need to figure out how come it's back again. If you feel the urge to pee, but you can't go. So yes, I know this isn't incontinence, but this is important. So listen up. If you cannot empty your bladder and you know it's filling up, that's actually a medical emergency. You need to go to emergencies so that they can catheterize you and empty your bladder. There is a point at which our bladders are overstretched and they don't recover well from that. And the last type of incontinence that I want you to think about, be aware of, and seek medical attention for is having unaware incontinence. So you don't know why you're leaking. You've tried to sleuth it out and you didn't have an urge and you weren't moving or coughing or laughing or sneezing at all, and pee came out. You need to know why that's happening. And so that too is a trip to your doctor. Okay. Okay. We're going to talk a bit about the anatomy because it's important to know what all the pieces are and how they work in an optimal environment. And then we're going to talk a little bit about what happens when the environment is no longer optimal. Okay. So this is a slice through the body of someone who was born with a prostate. We may call them a man, but we might not. So right here, this white structure is the pubic bone. So if you walk your hands down the softness of your belly, all the way to the bottom, the first bone you feel, that's your pubic bone. That's the bone that we have right here. I hope you can see my cursor at home. Right behind that is your bladder. Right underneath that is your prostate gland. And you can see the urethra travels right through it. This is where the pee has to come through. Long urethra in men. This back here is your rectum. Your external anal sphincter would be here, and your tailbone is at the back. This too is a muscle, but it's not a muscle we have direct control over, like our skeletal muscles. Your pelvic floor is a skeletal muscle. You have direct control over it. I'm going to show you more about that in a moment. This organ muscle of your bladder, you have indirect control. It, though, needs the right amount of exercise in a day, and it gets that exercise by stretching as it fills and contracting as it empties. There is actually a perfect number of times for that to happen in 24 hours. It's between 5 and 8 times a day. And I know for some of you with some overactive bladder and some BPH, benign prostatic hyperplasia, you're probably going pee a lot more times than that. Normal healthy scenario, this fills and fills and fills and fills. And at around 250 mils, you get an urge to go pee. And that urge is usually pretty easy to calm. You can think it down. You think, nah, not a good time. I'm in the middle of something. And your bladder goes, okay. Meanwhile, it's still filling. The second urge is sometime later. It does depend on what you've drank and how much. That urge, though, is a stronger urge because it's literally more full. Your kidneys are always filtering your blood. So your bladder is always being filled with urine, slowly, drop by drop, all day long. So that second urge, you might need a stronger thought, and you might need to recruit your pelvic floor. When we turn on our pelvic floor and we add some pressure down here, that's a no signal to your bladder via your spinal cord. Now is not the time to pee. So you've got your brain and your spinal cord talking to your bladder. Bladder says, okay, I'm okay. Meanwhile, it's still filling. Your third urge is a really strong urge. You are definitely actively looking for a bathroom because you're uncomfortable, but you should still have time to get all the way to the bathroom, get your clothes out of the way and say, okay, time to go pee. Normal, healthy scenario. Remember, this is what I'm talking about right now. At this point, peeing should be passive for you. Your bladder muscle contracts. This detrusor right here, it contracts, your pelvic floor relaxes, and out comes the pee and you empty. Even when you feel like you're fully empty, you've had the most satisfying pee with a really nice stream, there's still a residual volume left in your bladder. And that's a healthy, normal thing to have. You need that residual volume. It does mean that you can always make yourself pee, and you can always make yourself, or you might always be able to leak because there's always something in your bladder. Okay, so we know that that's the situation today with most of you, is that this isn't the normal healthy scenario. It's good for you to understand how it worked when it all worked well. I'll come back to that. This diagram are the muscles of your pelvic floor. So these are the muscles that physiotherapists are particularly interested in and that you are strengthening when you do pelvic floor muscle exercises, otherwise known as Kegels. So again, lay of the land right up here. These are your testes. So your pubic bone is at the top of this diagram. This pointy bone is your tailbone at the back. And these two bits of bone are the bones you sit on. So if you're sitting and listening, if you rock back and forth, you can feel those sit bones. Your pelvic floor is this diamond-shaped area of muscle. And it's all meant to contract at the same time. It's all meant to relax at the same time. It actually doesn't matter what you think of. When you fire it, you might think about firing and squeezing your external anal sphincter. If your pelvic floor contracts well, all of this musculature has turned on. These are the only muscles that can stop you from peeing. So they're really important when we start talking about incontinence. Okay, so just keep this diagram in your mind's eye. We talked a bit about this normal healthy scenario. You need this 250 ml pee. That's a good volume. And I've asterisked there that this is a goal. It's a goal for all of you. And I'm going to talk to you about some ways that if you don't think you're peeing at least a cup when you go, some ways to work towards that. You want to let your bladder fill to keep it calmer. So if you're peeing too often, it's something that actually increases your urgency and your frequency. If you're post-prostate surgery and you just can't keep any pee in there, it's advisable to actually lie down for periods of the day, like 45 minutes or so, to let your bladder fill some more. That residual volume is normal. You want to pee between 5 and 8 times a day. We talked about that. Okay, so this overactive bladder, what the heck is going on here? In overactive bladder, you get a thicker wall of your bladder. It actually starts to hypertrophy. It bulks up like you've been bulking up a muscle. And in a minute, when I show you a big prostate gland, you'll see why your bladder muscle is working so hard that it would bulk up. It actually grows more nerves and it is less extensible. And when you feel that strong, overwhelming urge to go pee, it's like all these things have come together to make that happen. It can't stretch, so it's instantly irritated and feels really full. And all those nerves really get talking and they cause a quick contraction, like before you're even ready to control it. So that's what's happening when you have overactive bladder and urge incontinence. As soon as your bladder contracts, you're going to pee. Oh, here we go. So this is the prostate diagram that I was wanting to tell you about. Excellent. This here it's on my left, hopefully it's on your left, is a normal size prostate gland. Look at how nice and big this urethra is. It looks like things could flow. The bladder's got lots of space. We come over here to this diagram on the right. This is simply an enlarged prostate gland. This is what it looks like when it's a benign prostatic hyperplasia. We're not even talking about cancer. This is just what happens to most male, we think maybe all male prostates, it starts to grow after the age of 25. So by the time you're 50, 60, 70, it's usually gotten quite big. It's often encroaching upon your bladder space. This urethra is definitely smaller than the one on the other side, so it increases the resistance to your pee coming out. And that's why your bladder muscle has to work so hard to try to get the pee to come. And often in this case, men start pushing. You start to have to push a little bit to get the pee to start, or you push to make sure that you empty. Some of the signs that you might have this happening in your body are having a lot of frequency, feeling like, boy, I got to go pee all the time. And even if I just peed, I have a lot of urgency. You might have that hesitation that it's slow to get started and it might stop and start while you're peeing. Or you might have a really slow stream. It just takes forever. You pee 250 mils, but it takes a long time. Well, it's going to take a long time because your prostatic urethra is really small. I often tell people that taking a long time to empty your bladder, no big deal. Try to just be patient, especially if you are actually peeing out that good volume. That's a healthier scenario than this is taking too long. I'm just going to give up and go away and only peeing a small volume out. You're guaranteeing you're going to have to come back. And that just increases over time the irritability of your bladder. Needing to push, we talked about that. And a feeling of not really being empty that might actually relate back to having urgency, but it might be that you really aren't emptying well and your residual volume is just growing and growing. Rarely do people with benign prostatic hyperplasia, I actually put all the letters wrong, that's so bad. So it's BPH, not BHP, pardon me, spelling error. Rarely do people with BPH have stress incontinence. Typically, there's so much resistance to the pee coming out that there's no way that you would cough, sneeze, laugh, and actually have incontinence. Where you might start to have stress incontinence is if you've been treated for your BPH with a TURP procedure, where they've actually widened out your prostate or prostatic urethra again. Suddenly, the flow is way open. There's no resistance or way less resistance to pee coming out. And then your muscle system isn't ready to take care of that. And that can be a scenario where after a TURP, you actually have to still have an incontinence management system to take care of your stress incontinence. That too can get better. Okay, so what do I do about urgency and frequency? Gillian, I have these problems. What do I do? The first thing you're going to do is learn a technique called urge suppression. And I'm going to talk about that in detail in another slide. But basically, they're techniques that let you calm an urge so that you can make it all the way to the bathroom, or maybe so that you can wait a little longer so you let your bladder fill. Remember that letting your bladder have some volume is an important thing to do. You might want to work on timed voiding. And this is especially if you have leakage and urge incontinence. So timed voiding is like, for one day, I want you to write down every time you go pee so you can figure out how often you actually are going to the bathroom and or leaking. And then I want you to put yourself on a schedule. And that literally means you will on purpose go pee every hour for the first couple of days. And if that goes well and there's no leaks, then you go to on purpose go pee every 75 minutes or maybe every 90 minutes. Try whatever interval is comfortable and doable for you. And then when that goes well for a couple of days, no leaks, you on purpose go pee a little bit longer apart. Do you see where I'm going with this? And this allows you to get in front of your leaking situation and your urgency, but then start to build yourself some capacity. What do we want? We want to be able to wait like 3 to 4 hours between times you go pee. And we want to at least have 250 mils to maybe, cross your fingers, 400 mils every time you go pee. Oh, there we go. Optimal bladder. We talked about that. You also want to avoid bladder irritants. So there are some things that can actually irritate your bladder and make your urgency and frequency much worse. These things include dietary things like spicy foods, citrus fruits. If you eat lemon and lime or orange, just a lot of citrus that can set you off sometimes. Tomatoes. If you're a smoker, nicotine is a bladder irritant. So sorry to tell you that. Alcohol is interesting because it actually increases your urine output. So you dump more urine into your bladder. It's a diuretic, so it shunts your urine there more quickly. So if you've got that bladder wall that's not very elastic and you're dumping fluid in it really fast, you might suddenly fill and reach a place where it gives you a signal. Being dehydrated is also an irritation. Our urine is actually, the chief ingredient is uric acid. So if we are dehydrated and it super concentrates, it becomes acidic. And that's a bit like having vinegar against your skin for a long period of time. Our bladders don't like it. So it's important, even though you're having problems with how much you go pee, to stay hydrated and drink more. Carbonated beverages that have bubbles can irritate your bladder, and artificial sweeteners like aspartame, sorbitol, these things can also be irritants to your bladder. And remember, you don't want to go too often, and you do want to allow your bladder to fill up. Okay, so this urge suppression technique. This is important. So every time you get an urge, especially if you're trying to put an urge off, these techniques, by the way, are good for the partners of the people who were born with prostate glands as well, if you happen to have urgency and frequency. This works for men and women, all the sexes, all the genders. Okay, so first step is to stop what you're doing. And if possible, to actually sit down on a firm surface. A firm surface against your perineum is clearly not a toilet, and your brain and your bladder know this. You might want to try contracting your pelvic floor. It's true that if you don't know how to contract your pelvic floor, this may not be a good idea, but we're going to assume for this moment that you do know how to use it. Use your stop pee muscles and turn them on. You want to try to stay relaxed in the rest of your body and keep breathing. So what this doesn't look like is, okay, I got my Kegel on. As soon as you tense up your whole body and hold your breath, you increase your intra-abdominal pressure, you push on your bladder, and you irritate it more. So you have to stay calm, breathe, and contract. And most importantly, you need to distract yourself. You've probably already noticed that if you're busy and involved in something, you don't feel like you have to go pee as often as when you're a little less involved in something. These techniques might need to be repeated to be successful. And success means that the urge is completely gone, you're quite comfortable, or that you've taken that urge from a scream in your brain to like a dull roar. That lessening the severity of your urge does actually buy you time to get to the bathroom. It's like, well, I have an awareness my bladder is irritated and full, but now it's not going to be an emergency. After you've calmed your bladder, you may always choose to go pee, but you got to calm the urge first. And the way that you get success with this is to calm every single urge that you have, even if you think that it's warranted to have it, so that when it's an urge that's outside the ballpark, you know you have confidence with the skills. Okay. Now we're going to talk a little bit about prostate cancer. I'm not a cancer specialist. So I'm not coming to you from the point of view of an oncologist at all, but just some basics, because a lot of the people here we know will have had experiences with prostate cancer currently or in the past. And that's why you're having your incontinence, or you're thinking about treatment and you've heard incontinence is a thing. So there is a lot of stress incontinence that goes along with treatments for prostate cancer. Prostate cancer can be very prevalent. It can be quite treatable, especially when caught early. Treatment protocols definitely vary, and it's a complicated decision-making process that's best done between yourself and your oncologist. But these treatments for prostate cancer can come with side effects. Active surveillance doesn't come with much of a continence side effect at all. If you have BPH before you got prostate cancer, you might still have those types of urinary symptoms. Brachytherapy, which is the implanted radioactive seeds, 50% of people with brachytherapy will have urgency, frequency, slow stream, and hesitancy, which sounds a little bit more like BPH, doesn't it? Yeah. People who undergo a radical prostatectomy will often experience erectile dysfunction and stress urinary incontinence. It's kind of like 50% of people that have had a radical prostatectomy will have erectile dysfunction. And a wide range of data tells us like 2% to 90% of people with radical prostatectomies will have stress incontinence. It's kind of a huge field, and I'm going to say a little bit more about that in a minute here. External beam radiation treatments to shrink a tumor also come with urgency and frequency of your bladder and potentially your bowel. The androgen deprivation therapies that sort of suppress your testosterone don't necessarily come with urinary symptoms. And of course, palliative care doesn't come with any specific or special things to do with urinary changes necessarily. Oh, so here it is, this 2 to 90%. So this, how often do people experience these side effects? Well, the research is not in agreement on this. And part of the reason for that is that actually studies about men are few and far between. Incontinence in women is much more prevalent across a lifetime of a woman or person with a vagina, born with a vagina. And so it's been studied quite a bit in women. And this is one of those places in healthcare where not enough research has been done for men, in our opinion. Many people will have some kind of erectile dysfunction afterward. I'm not going to talk a lot about erectile dysfunction, but just to say right here that even if you cannot ejaculate, which after prostate removal, you won't be able to, and you do not have an erection that would allow you to have penetration, or you have no erectile function at all, you can still experience arousal and you can still experience climax. So intimacy is not necessarily something that has to go away just because you have some erectile dysfunction. And there are a lot of resources about these concepts out there. And I'd encourage you to reach out if you have questions about that. Okay, so a little bit of anatomy is important here. And where this comes in is like, why do I get stress incontinence? Well, this here is your prostate gland. Hopefully you can see my cursor on that purple drawing. At the top is the internal urethral opening, and the internal sphincter is here. This will definitely be damaged in the process of removing the prostate gland. The surgeon has to get what are called clear margins, and they will take the internal sphincter. The striated muscle sphincter, which is part of your pelvic floor that you have voluntary control over, is here at the bottom. And it's really neat. The cells of the muscle, they're called striated cells, of the part you have voluntary control over, actually overlap and interlink with the smooth muscle cells of the prostatic urethra. So some things you have control over, this bit you don't. The amount that this overlap happens, where it goes from being all stuff you can use to control into kind of a mixture of that into all prostate gland, it differs between people. And when the surgeon goes in, they have to get clear margins, which they do. And then how much cells that you are left with in your external sphincter that you can use to create your contraction varies depending on your unique, your DNA essentially, and how it laid down your unique cells. So when you're in a room and you're talking to a bunch of guys about, you had the same diagnosis and the same treatment as me, you had the same diagnosis and the same treatment, but we all have different amounts of incontinence at this point. That's one of the reasons why things might differ. Okay, I hope that was clear. So what you need is a system to manage your incontinence. This can include physical therapy treatment, exercises for your pelvic floor, some education and support around what should I try next? Why isn't this working for me? These are things a physiotherapist can do for you. I'm going to get into specifics in a moment. The other parts of your incontinence management system include things like the protection, your garments, your pads, your, I'm going to say a TENS or a TENA, your garments. These are really important for use for a period of time, because they will give you the freedom to go out and do things despite the fact that you leak. You want to consider potentially clamps or catheters, and I'm going to show you pictures of these, or even urethral inserts, like for instance, the Contino that Life 360 has put on the market. There are some medications that only work for urge incontinence. You can definitely talk to your physician about them, but they aren't actually tolerated well. And there's some data that these medications can be linked with dementia in later life. So you need to really consider this very hard if this is on your list of things you're willing to try. And if you're still leaking after all of this and you're just not satisfied, there are some surgeries like a bladder lift or an artificial sphincter. And I'm not going to talk much about these surgeries. or other invasive procedures, because it is not my wheelhouse to prescribe them to you or actually do them, but just so you know that these are options. Okay, do pelvic floor exercises work? Gillian, I got to go to physio. You said I do, but is this really going to work for me? There is data to suggest that it will improve your continence or return to continence to do pelvic floor exercises. They are best done, the research says, using some device for biofeedback, which I'm going to show you. And a pre-op visit where you see the physiotherapist before you go for surgery also can be beneficial and come with better outcomes. There's so moderate evidence for having success with pelvic floor exercises after prostatectomy surgeries. It's unlikely to help people post-TURP is what the research says. There's a lot of variation between studies, unfortunately, as I mentioned previously. And what we actually need are more rigorous, adequately powered, randomized control trials of people that were born with prostates and what happens for them when it comes to this incontinence issue that you're having. So for now, I'm going to leave you with, yeah, physiotherapy can be extremely beneficial for you, but I'm not going to tell you that it's going to be a cure. It's part of your system, though. So this pelvic floor muscle, remember I showed it to you earlier, it is a tool that you have with you all of the time, 24 hours a day. You don't have a spare pad in your pocket. Hey, don't worry, your pelvic floor is still with you. So this actually trumps all the other things that you might try conservative management wise, because it's easy. It's already there. You don't have to pay for it. It's still in your body. Physiotherapy is going to teach you how to use your pelvic floor, when to use your pelvic floor, and then it's going to train you to give you the strength and the endurance to use it well. You still need to remember to use it. So a session with a physiotherapist often includes a lot of education, some of the things I've already covered with you, but they're going to cover things that relate specifically to you and your body and the things that you come talking about. Some physiotherapists also may fit you for a Contino urethral insert, but that isn't necessarily a part of a physiotherapy visit. So just be aware of that. A good trial of physiotherapy is at least 6 to 12 weeks of good quality contractions with consistent, proficient pelvic floor exercise practice and a commitment to using your pelvic floor in functional use. Usually a session of physiotherapy is between half an hour to an hour long, and it's definitely going to involve some exercises. So right now, this is the audience participation part of our evening. What I really want you to do is wherever you are in your chair, I want you to squeeze the muscles that would stop you from peeing as tightly as you can. Everybody can do this. Your pelvic floor is there for you. Squeeze it, keep it squeezed. Try to use them up, try to turn it up and make that muscle work really hard. Try to do that for me. Okay, and relax. Now, how many people here, and I won't take a show of hands, but think to yourself, when I said relax and you let go, how many of you felt your glutes relax? I bet quite a lot of you did. How many of you felt your abs relax? How many of you felt like you were holding your breath and you let it go when I said relax? Yeah, so I hate to tell you, but those 3 muscle groups, while really common to use instead of your pelvic floor, cannot stop pee from coming out of your body. And that's an indication, a strong one, that you should see a physiotherapist and get some biofeedback and learn how to do this muscle properly, this exercise properly. So what's biofeedback? This is first you need to know how. What you can see on your screen is my laptop, and it's got this picture of these little squiggly lines. This is the readout of a biofeedback device. On the far right of that same picture, this thing with all the wires sticking out of it is the biofeedback device. And of course, there's a pelvic floor diagram in the middle of it all. This treatment is done externally. So you'd be happy to know it does not involve any internal palpation or work at all. And in fact, if you look at the diagram on the left side of your screen, you can see these little stickers with leads. This is an example of where we place the biofeedback leads. So yes, we're all up in your business, really close to your external anal sphincter. We're going to put 2 stickers. And those stickers are actually the electrodes. They're going to send information to wirelessly to the computer. And that displays there on the right. This is the example of a spike, which is a quick on off. Over here is an example of a ramp exercise where we've asked you to gradually turn on your pelvic floor and hold it for a period of time. And you might see in the diagram, there's one little sticker over here on the side, and that's because they always have a reference electrode that attaches to your inner thigh. It is very easy, non-invasive, and super useful. You see that diagram, you see the thing on the computer screen, and you know, oh, I'm using my pelvic floor well, or, oh, I am not using my pelvic floor well. It's very clear. Then when you have enough skill, you have to build your strength and endurance. So that means at least 3 sets of 10 repetitions where you hold your pelvic floor activity at about 80% of full for 10 seconds at a time, and then rest for 10 seconds. 10 seconds of work, 10 seconds of rest. You'd want to do a 30-second break between sets. And you could do this every other day for a period of time, but you have to do your contractions really well every time you do them. To build your endurance, and this is key because often the leaking is worse later in the day when you're getting tired. And if that's the case for you, if you're like, oh yeah, about 4 o'clock, I start leaking, that's interesting. Well, for goodness sake, go lie down, take a break. This is a good time to lie down and let your bladder fill and have a rest. And as part of your exercise program, separate to that rest, you want to build 3 contractions that are at least 30 seconds long. They don't have to be maximal. They should only be about 60 or 70% of your maximum. A long, long, long hold time. And that will build your endurance over time to help you combat that later in the day increase in leaking. Okay, and lastly, you need to use it. Functional use, which means, oh dear, I'm going to cough. Contract, do your task, your cough, your sneeze, your lift a box, finish that activity. So stop coughing, stop sneezing, or put your box down, and then relax back to normal. The one that maybe we should talk about specifically is getting up out of a chair. This is particularly challenging for those born with a prostate. Stand up out of a chair and leak. Well, commit today. Before you stand up, contract. Stand up and hold your contraction for the length of your stand, and then relax when you've got into standing. And you might find that you handle that much better. Okay, so some hints, some things we've already talked about. That preoperative PT session is generally quite useful. It's got proven evidence that it is. Afterwards, your nighttime control is going to come first. And this is great. It's evidence of sphincteric function returning, right? And then because your bladder is more full, you can actually make it to the bathroom and not leak. And that's the one time all day that will happen until you lie down and let your bladder fill again. We actually might use, and there are some protocols out there that don't have enough robust evidence, but we're working on it, like using clamps or using the Contino to block the leakage so that your bladder actually fills, to actually stimulate that sphincteric function to help you actually not need to use those devices and have better control. So it's a reason to maybe think about, okay, a clamp sounds kind of uncomfortable, but I'll give it a try. Okay, pads or briefs. What you want to do, especially early on if you're leaking a lot, is get the entire garment, wear the brief, and put a pad inside of it. And when your pad is wet, then you change your pad. You're not constantly changing briefs because that can get expensive. It's also like a doubled up system. So you're never caught out in the world, in a golf game or a social situation without some kind of backup plan. You can get free samples if you like. So there's on the screen, there's one example of where you could find free samples. If you go to the website, there'll be a link, free samples, and they'll send them to you. You just request them. There's other brands as well as the one that I've mentioned. Poise and Tenna are usually the big ones. They're comfy when they're dry. They're really easy to use, but they are most likely to leak, and they can be really uncomfortable when they're wet, and they can come with an odor. And those are the things that can be kind of challenging. Another type of support system is this condom drainage. It's a condom catheter that you put onto your penis and then just drains into a bag, a leg bag. And then when you choose, you can empty the bag. Keep in mind that when this condom cath is in place, you're not holding any urine inside of your bladder. You're not letting it fill. But it's good for extended use. I want to go play golf. Awesome. Use a condom catheter. It doesn't leak when it fits well, and there isn't any odor at all. So you don't have that problem like you did with the pads. But it can be difficult to apply that condom. Penises do retract. They get smaller post-radical prostatectomy. The biggest mechanism of getting smaller is the blood flow changes. So immediately your penis can be a very different size. And so it can be hard to keep this condom catheter on. Okay. This is an example of a clamp. I think it's the Uriclac. A clamp can be between like $75 and $125. You can order them online. So there's not a serious price point to it. You can wear them for only a couple of hours at a time. And people do report that they can be uncomfortable to use. But when they fit well, I'm told it's not too bad. You do need to have, enough cognition that you can sense when, oh, it's been too long, I need to take it off. You need to have good normal genital sensation so that you be aware if your skin was breaking down or the pressure was too much. You need to have intact skin. And so staying dry is really important so that your skin does not break down, right? And you need to have a system that helps you manage enough that your skin's not breaking down. It's good to have an awareness of your bladder filling, because if you leave it too long, then your bladder can overfill. So these are just some things to keep in mind. But it is associated with some studies that suggest an improved quality of life when you use them. There is very little safety research with these devices. So keep that in mind. Another, pad physiotherapy co-pilot is the urethral insert, like the Contino. This for people is often a pretty big leap. They think, I've got to learn how to put something inside my own urethra. It might be interesting for you to know that this is in the same category of medical device as a contact lens. So for those of you that have never worn contact lenses, you're like, somebody learned how to stick something in their eye. That's crazy. But a whole bunch of people successfully use contact lenses. They learn how. You learn how to put this device inside your urethra. It does do a good job, and studies have proven, of completely curing the leak problem, or at least reducing it greatly. But sometimes you have to still use a pad, and it's always going to work better if you have good strategies and good strength in your pelvic floor. What do I want to say about this? In the beginning, there can be mild discomfort and slight bleeding. And that's just a timer that I use to keep myself on track. So I'm going to keep going for a few more minutes, but I'll wrap it up soon. There can be mild discomfort and slight bleeding at the beginning as your tissues get used to using the Contino. There is a fitting process that helps you to kind of get over this stage before you sink a lot of dollars into trying it, to make sure it's going to be a good option for you. And for some people, it's a fantastic option. Okay, here we are. Surgical options. So say you're still leaking. You've tried these things. It's been some time, and you're just not satisfied with how things are going. There are more invasive options available to you, and these are best discussed with your doctors. And you'd need a surgeon for most of them. So there can be injectable bulking agents that help give the urethra more resistance to the flow. The male sling, or there's also an adjustable transobturator male sling. And there's an artificial urinary sphincter that can also be inserted. These potential procedures all come with side effects and potential complications, and it's best to talk about whether it's suitable for you with your surgeon. They're usually not going to talk to you about any of these surgeries until you've at least had a year post-op from your prostate surgery. And to be honest with you, they're also not a guarantee that you'll have continence after you try them. So it's definitely something to be weighed. Okay, remember the goal. The goal is that you want to live life fully and with joy. You want to get out there and do all the things that you love to do. And you need to have full confidence in your incontinence management system to do this. The best kind of system is your physio with a protection mechanism. A combination of all the things I've talked to you today, overlapping, is really your best way to go about managing your incontinence. These are some resources that you can access. For people in British Columbia, and I assume some of you are in BC, there's this fantastic program called the Prostate Cancer Supportive Care Program. It's different than the prostate cancer support groups, so supportive care program. And it has tons of resources and services that are available to you, including physiotherapy, an athletic trainer, a sex therapist to help you with your penile rehabilitation for free for the rest of your life once you've had a diagnosis of having prostate cancer. Pretty amazing. In Ontario, you can contact Cancer Care Ontario to see what kinds of support is available in your area. And if you're in an area and you're having trouble, do reach out because we might be able to link with our networks and find you some support in your neighborhood. I'm so grateful that I was able to be here today to have this conversation with you. I am going to stick around and answer any questions that you might have. And I do hope that I've added to your arsenal, to your confidence that you can move forward, make decisions, and come up with a good system for your incontinence so that you can live your life the way you hope to. So I'm going to stop screen sharing at the moment. There we go.
Thank you so much, Gillian, for the wonderful talk and overview. There's a question just to get things started from the chat, okay. Which is just, and you talked a little bit about resources towards the end and places you can go for help, but is there a list of physios who specialize in the topic of pelvic health, and how might somebody do more research to figure out someone in their area?
Someone in their area, that's such a great question. So certainly here in the province of British Columbia, you can go to the British Columbia website, or it's the Physiotherapy Association hang on one second, PABC, Physiotherapy Association of British Columbia. That website is bcphysio.org, bcphysio.org. In the top corner, it says find a physio. And you can actually put in your postal code and your search parameters. I'm looking for a pelvic floor physiotherapist. I want treatment for incontinence in this postal code area, and it will come up with all of the options. So I think Andrew's just put that into the chat, bcphysio.org. I am not certain about if those lists are available with other associations, but you certainly can also try to get a hold of the the Canadian Physiotherapy Association. So that's our national body. That's physiotherapy.ca. Pardon me. They have a special interest group where they have created lists of practitioners all across the country, physiotherapy.ca. That might be your two best places to start your journey. The third option that you could do, again, is reach out to Life 360 and they can ask their network to come back to them with, hey, this person's in Scarborough, and I'll come back to you with as many as I can, or so will my colleagues.
Excellent, thank you. Okay, so there's a question here in the chat. Thank you for that. So the question is, with inserts like Contino, how do they work on a day-to-day basis? How would one incorporate these types of products into your urinary plan?
Right. So the Contino is really interesting. Well, I can start, Andrew, and if you think you want to add,
go ahead. It's your floor.
It's my ball game. Yeah. So the Contino insert is a device that once you've gone through your process of acclimating your body to using it, you can actually have inside all day long. There are wearers who will even use it throughout the evening or the night. But say it's daytime and you're going to go out and be active, you insert your Contino device or your urethral insert. And if you are completely continent when you have it in, then you don't need to add a pad. If you're worried about leakage, you could have a pad just in case for drops, for scenarios where maybe there's too much stress on the system and a little bit sneaks out. And then your bladder would fill and you'd get an urge to go pee. And so, okay, I have an urge. You'd go off to the washroom over the toilet. So this is actually best done in sitting. You should sit down with clean hands, by the way, and you remove the urethral insert and allow the pee to come out, and you have a full pee. And then you clean it and your hands and you reinsert again And your physiotherapist that you work with, along with the nurse continence advisors that work with Life 360, will teach you how to do these things. It sounds really onerous at the beginning, but we teach you how. Oh, there you go. Book a meeting with your Contino nurse to learn more about the specifics of those details. So you've peed, you put your insert back in. Now you're not going to leak, or your leakage is contained, and you can go on with your day. I hope that answers your question.
Thanks, Gillian. Hopefully we'll follow up with the person that asked that question just to make sure afterwards. I have a couple of questions that others submitted, but I just wanted to check with those that have dialed in today. Feel free, you can unmute yourself and ask a question. Otherwise, and if no one does, then I'll go to these other questions, but I'd kind of like to give people a chance if they have anything while we've got you here, just for a couple more minutes. So does anybody on the line, would they like to ask a question? Now's your chance.
I mean, Ronald would like to. Hi.
Yeah, go ahead.
So I followed your presentation through, and at the very end, I've had a TURP procedure just about 9 weeks ago.
Okay.
And did I understand from your presentation, however, that the exercises, the Kegel exercises and stuff like that, do not work in that after that procedure?
No, what you understood from that slide is that the research has been mixed. So
I'll take that as a no.
I wouldn't actually guarantee that it's a no, because what happens if you're having stress incontinence, so you move, you laugh, you cough, and you leak, is that they've tunneled out that space, if you will, in your prostate. You haven't had this much of a pipeline for, we're going to say, probably a really long time. And so suddenly your body has this ability to let go, and you don't have the kind of the automatic features to your pelvic floor and your sphincteric control anymore. You can build that back with some exercises, the muscular control. Yeah. So while I would say that I cannot guarantee, I actually do think that it's worth a try.
Well, I have mixed. My GP says no. My urologist says give it a try. So
there you go. And you know why? That's because the research is like.
I'm sort of up in the air about giving it a try, but I've got to do something because I have zero quality of life at this point in time. Yes. The other thing I have is that I appreciate the difference between stress and urgency. I don't think I have stress incontinence, but I certainly have urgency. I can be sitting here now for an hour because I've just voided before I came. I can sit here for an hour, stand up from my chair, and man, I've got to go to the washroom right away.
Yeah.
Or I'm in the car riding because I've just come home from someplace and I've got a 2-hour, I live just outside Toronto. So I've got a 2-hour drive home from downtown Toronto to where I live. If I don't void myself before I leave, I've got that urge then, urge incontinence on the way. And there are times when I've not made it. So thank you for helping me understand what's going on here. I appreciate that very much. And I was the one that asked about physiotherapists that might be able to help me out. My wife had gone to one here for a situation around some of her issues. And so we'll see whether that person can help me out in this regard. So anyway,
I really hope so.
And I'm looking for copies of your slides, please.
I'll have to talk to Life 360 about that for sure. What I would say too is that not all physiotherapists who treat women also treat men. So give that clinic a call and see. And if you run into a roadblock, Ronald, reach out. We'll try to find you somebody.
I appreciate that very much. Thank you very much. I enjoyed it very much. Thank you.
Oh, thank you.
Thanks for your questions. So in the interest of time, we've got a couple of minutes left. One more question came in the chat, Gillian. So we got for you. In losing the sphincter in the prostate, are the remaining sphincters sufficient to give you close to 100% control?
Right. So if you can remember what that slide with that purple prostate, the answer is it depends. And it depends on your unique anatomy. So while we're all the same, and we had, well, all men are the same, they have a prostate and that external sphincter that's left, those cells that overlap with one another, that's what's different between bodies and how much the surgeon has to take. So what's left, that's what's different between bodies. It can be, and actually after about a year, the data, some would suggest, it's a weak data, but we're trying, that only about 30% of people still have incontinence a year after surgery, severe incontinence a year after surgery. And so there's a whole lot of people that do recover and they do well enough. They have minimal or no incontinence at least a year later. So it depends. It may well have enough cells that it can give you 100% control.
Thank you. Well, I think now here we are at 6 p.m. In Vancouver and 9 in Toronto. So thank you, Gillian, for a wonderful talk and answering those questions. Thank you to everybody for taking the time to join us today. We hope you found this to be helpful. We'll be sharing the video afterwards. And this is something we will likely do maybe every 3 months. We'll likely do a talk like this. So we will be reaching out for the next one. And if you have, if you have networks, we find often men dealing with this have networks. If you know somebody that might find it helpful, please share with them. We'd love to help them too and include them. So with that, thank you, everybody. Gillian, any final words from you?
Just good luck, everybody. I hope it goes really well for you and that you get to enjoy your summer.
Okay, with that, great evening, everybody. Bye-bye.
Bye.